Good morning, everyone. I'm Michelle Stoffel, faculty pathology informaticist, and today I'm going to talk about one of my favorite topics, which are the differences, but moreover the similarity between AP and CP in relationship to the data they produce. I have no disclosures relevant to this topic. So my goals for this session this morning are to outline the history of AP and CP as disciplines in the context of how they produce the data that we have today, and to highlight some of the barriers to integrating AP and CP data for clinical and other use cases, using examples where I think there's the greatest need. And then we'll look forward to the future and describe some evolving strategies to optimize AP and CP integration. I'm presenting from a laptop at the lab today, so if for any reason you can't hear me or see something, just stop and interrupt. It may be challenging to monitor the chat. I'm just going to move my little bar out of the way for a second. Oh, okay. So as everyone in this audience, I'm sure, is aware, there are historically separated disciplines within pathology that are really united by pathology being the practice of delivering diagnosis and care based on specimens taken from patients. Historically, anatomic pathology has dealt with tissue samples obtained by procedures and typically involves microscopy. This tends to be labor intensive, and there are generally a lower volume of anatomic pathology tests performed by a larger number of individuals. And classically, disciplines like surgical pathology, cytopathology, forensic pathology fall into this category. Clinical pathology, it's not just the absence of anatomic pathology, but this has tended to be used as a larger kind of bucket for anything that's not that AP technically fits in. It's a wide array of disciplines that is, for the most part, has dealt with fluid-based samples, and the classical disciplines that squarely fall into CP are clinical chemistry, microbiology, and transfusion medicine, which is really a separate specialty and won't talk as much about today, but that has fallen more into the CP category due to the blood samples part. And then I've highlighted here in purple, however, that there is lots of overlap, especially in the practices that cross over and do multiple studies on a single sample, such as hematopathology, transplant pathology, and molecular genomic pathology. And historically, these may have been either in AP or CP departments and or in different AP or CP parts of LIS build. So, oops, my thing's not advancing. Just a sec. Okay. So talking about the history of all of these specialties would take too much time for this talk, but using anatomic pathology just as an example, while some histories of pathology trace AP practice, back several thousand years actually, most disciplines of pathology, including AP, really started to resemble the practice that is recognizable today, sometime in the mid to late 19th century. And then most disciplines of pathology really started accelerating in terms of the available analytic techniques and complexity of testing through the late half of the 20th century up to today. So it's really been this 50 to 60 year time span that we've seen a big acceleration of techniques and complexity of change that mirrors the advances in medical science. So that 50 to 60 year time span also parallels the advent of of computers and the development of pathology informatics as a discipline. So this chart, it's very text dense, but it just provides a visual timeline of the major milestones in pathology informatics over the last 50 to 60 years. And really what I just want to call out here is that most of these milestones are agnostic to AP or CP. They're milestones in data as data. So things like standard for interoperability, like the development of LINC and SNOMED, development of professional societies, introduction of computational techniques, and even the authorship of this article represents leadership in anatomic pathology and transfusion medicine, respectively. So pathology informatics by nature is a cross-disciplinary practice. However, our lab information systems, these applications that are used to process data and to perform and to interface between each other and the EHR and external systems, these have historically been developed to support the historical practices of AP and CP and blood bank separately. And so up until recently, really the mainstay of LIS has been the so-called best of breed systems. We've had several legacy systems here that we now have archived, and these were really tailored to to model and support those historical workflows. So our LIS systems have likewise developed separately by AP and CP designations, and this has created separation of the data today. Now, with that said, more recently, I'd say in the last 10 years, there's been a trend of migration to having LISs that are an integrated module of your larger EHR. And we have that today here at Fairview with our EPIC EHR and our AP and CP Beaker modules. With that said, even when the EHR contains the LIS as its own module, AP and CP built as separate modules still tends to be common, and these can have different functionalities, different access. Because for blood bank, because of the requirement for FDA approval of the software, there are a few EHR systems that have integrated LISs. So we're still working in a scenario of having some separated LIS systems today. So the digital workflows that have evolved in the LIS and EHR systems have really historically been built to mirror the pre-existing physical workflows and output. And we see this as an example I have here from our test environment in our whole slide imaging Leica eSlide Manager web viewer, where the pathologist will be sitting in front of this user interface. The software has been built to show slides that are in a representative digital slide tray that looks essentially identical to the cardboard tray they would have in the physical realm next to them. This isn't necessarily a bad thing. In many cases, these workflows have developed over decades and are safe and intuitive for making sure that you're looking at cases in a sequential manner. And then they also may be important for scenarios like we have today, where we're working in a hybrid digital and analog world. And at times, the same pathologists may need to work in either or for the example, where our pathology reports digitally are really formatted the same as they have been, similarly as they have been on paper for decades. And this can be useful because sometimes they need to be printed out or used in downtime scenarios or faxed. So there can be reasons for this, but just to highlight that really historically our technology has been sort of chasing or following, I think, the pre-existing way of working and behind, I think, the innovations in practice. So when we talk about the characteristics of data, of lab data, especially I think when it comes to differences between AP and CP data, it's helpful to define some the content we're talking about and some characteristics about it. So when we think about data content for lab tests. First to mind comes, results. So result values, whether they're text-based values like a surgical pathology report, or numerical values such as a clinical chemistry result. And then case-associated images like flow cytometry, plots and the data behind them, as well as whole site images and the data behind those, can also be thought of as report content and or the diagnostic interpretation of material itself. In the EHR, there's a lot of other data that's generated associated with different actions by either the clinic, the lab, or behind the scenes by the system, and common actions that may be pertinent to our data are data around orders, collection, routing, and interface messaging, etc. Now, all of our pathology data falls somewhere on a spectrum of what's called structuredness. And this image on the right illustrates this in a kind of pyramid graphic. But at the top, we have the structured data. And you may also hear structured data really is kind of just synonymous with the term of discrete data. And I like this idea of discrete data because I think it's very intuitive. And I think the most practical way to think about it is, a discrete element of data is an element that's, for practical purposes, indivisible. And so, thinking about a clinical chemistry numeric value as a discrete component. Now, you can argue, when it comes to like a character string of several words, that can be a discrete, component as well. That's not purely indivisible, but for practical purposes, I think this is helpful. And so we have a lot of our data that is, highly structured or discrete. And then we move into the semi and quasi-structured data. And this is data that can have a lack of standardization, but there will often be some formatting or structure to it, or it could be structured with some effort. An example of this would be surgical pathology reports, which may be variable in their content, but will typically at least have common subheadings in different sections. And then when it comes to our pathology data in terms of it containing, human readable text characters, unstructured data includes elements like image files and video, audio, etc. And so these really have no inherent structure without additional processing. So what makes AP data, AP and CP data, CP? The short answer is nothing. It's really just, there's no hard and fast rule other than how these have been historically practiced and how we have built them into our systems. But with that said, there are some overarching characteristics that tend to fall with AP and CP data respectively, and these are due to those differences in practice and the way that we've built these results. And so this table from the clinical toxicology literature, where in clinical drug trials, it's very important to be able to associate AP and CP data for subjects. This is recognized as a challenge. And so some characteristics overall of clinical CP data, I mentioned before that it tends to be discrete, usually is more quantitative, so numbers, categorical values. It is more, I would say, objective in terms of, automated and sometimes auto verified. And because it tends to be done on, blood or fluid samples, the clinical values it provides give a global snapshot of the status of the individual at that time. And also because of the nature of using fluid samples, it's non-invasive or less invasive compared to AP data from a clinical and quality standpoint. By nature is qualitative and subjective, relies on training of individuals, and then I would say overall it's historically been qualitative with the advent of less subjective elements like IHC and some molecular reporting. There have been additions of objective data into AP, which has caused some data issues, as we'll talk about. And then because of the invasive nature where a biopsy or a resection is performed, this also, the data conveyed is local to the sampling and also may report expected or normal findings, in addition to delivering a high degree of certainty when abnormality is found. So those are some differences from a kind of clinical and quality perspective. When it comes to our EHR and LIS build, there are some additional considerations. So CP type of tests in our LIS, these tend to be ordered by clinicians in the EHR or by a clinician delegate. So they're ordered in the EHR, and then at least the order is usually immediately visible to all, and they contain these timestamps that tend to have kind of standardized timestamps such as order, collection, verified, etc., that are visible. And because these tests tend to be shorter turnaround time, tend to be rather predictable in terms of when physicians can expect to see their results. As has been mentioned before, the result values are typically discrete or categorical, not in all cases. Some tests do also have unstructured text components, although even those tend to be more standardized in CP tests. And the way these tests are viewed in the chart, in the EHR chart, overall, and also in our EPIC chart, tends to be in an aggregate, the so-called results review, grid view, or in different chart trend lines and displays in the chart. And for that, it's important that not only the result value component goes along, like the number 15 below, but then also the components, the data components that contain the reference interval, the timestamp, et cetera, so that the result is not misinterpreted. Typical AP data from an EHR perspective has some key differences. Overall, the test itself, such as a surgical pathology exam on a biopsy sample, these tend to be ordered. I mean, they're usually ordered by the clinician, but there is essentially orders that happen at the patient level, and then there are often additional orders that happen at the specimen level, and this comprises the diagnostic workup that may be ordered on the specimen in terms of IHC, molecular pathology orders, and this may be ordered. Many of these are ordered by the pathologist, but there are times where these tests may be ordered by clinician, and depending on the system and the culture and the workflow, it could be either or. And so this can cause some potential confusion if it's not clear which roles are ordering which parts of the workup on a sample. Because of the relative longer turnaround time of AP tests, which tends to be in days and even in some cases weeks in cases of cytogenetics, the status of the EHR tends to be more obscure to clinicians. Not to say that these tests don't have actually probably similar timestamps as CP tests, but they tend to be less useful to clinicians in terms of being able to predict a tight time frame when they'll get the result. And then the result contents for these tests are predominantly unstructured text, and they're also usually clinically accessed and read from the lab tab in chart reviews in the EHR. As I mentioned before, AP tests increasingly contain some discrete components such as cytology classifications, like for example, the Paris categories or PAP categories, as well as the CAP synoptic protocol forms. Today, for practical purposes, the discretization of AP data is pretty much limited to oncology scenarios. But however, there are many other more objective features that are commonly reported in AP tests, such as kidney transplant, standardized elements, and for colon biopsies, et cetera, that would be amenable to containing in more structured data, but it's just not done today in most cases yet. And for those unstructured components, because of the individuals involved and depending on the culture and the system, there may be a spectrum of standardization in terms of formatting. And in all cases, it may not really be feasible to completely standardize reporting in the way that many CP tests are done. So I've given a little background there, and I'm going to take the next section to highlight a few example use cases for AP CP integration optimization, and as part of that, highlight the barriers that we face in integration in our current state. And these examples will come from they're from our EPIC EHR. This is the world that I live in, and most of you practicing here do as well. So a key data integration challenge for AP and CP data is this issue of data visibility in the EHR. And I just want to call out that this really isn't inherent to AP or CP data. It really has to do with data from tests that are performed in different labs at different times, where it's difficult for the clinician to see in space in the EHR and in time at the time of result. Tests that would be useful to see side by side. AP and CP, when the tests are built separately as AP and CP, because of how I talked about they're viewed in different parts of the chart, that makes it more complicated. But this can also be an issue even for CP tests from different labs and together, or AP, vice versa. And so some kind of classic AP-CP pairs that it's helpful to view together are examples like the molecular pathology and surgical pathology reports, hematopathology, which tends to be built as AP testing, and hematology, which tends to be built as CP testing, cytopathology, which is AP in most places, with microbiology, which is typically built as CP tests. So for an example, with molecular pathology, if we consider oncologic molecular pathology, apart from the larger conversation of what comprises molecular pathology in terms of the genomic workup that is needed to be able to care for a patient for a specific condition, we also consider this from an LIS standpoint in terms of what is molecular pathology. From an LIS build. Is it AP-CP? Is it both? In reality, we actually, most of what we might consider the molecular pathology tests listed here have elements of both, AP, such as, a unstructured report comment versus, or with CP, such as, discrete or potentially discrete, genomic results. That we may build the tests as a hybrid, or there may be multiple individual tests built as either AP or CP that comprise the sum total of the workup needed to care for a patient. So it kind of begs the question, not only why are these tests sometimes AP or CP, but the answer really being because they are originate from different labs and are signed up by different pathologists and are built in different ways in our historical context. But it also kind of begs the question of why are we actually dealing with separate reports when really what would be ideal is kind of one master report for a single workup. So I want to highlight an example of a way one system has effectively achieved this. So this is from a recent EPIC webinar on the EPIC user web. I'm happy to help anybody who's interested in watching this get the access they need. But this is from Children's Hospital of Colorado, and this is a solution that they achieved using EPIC's capability for order linking. So, orders, whether they come from radiology procedures or biopsies or labs, can be linked together in EPIC. And so this group has leveraged this to coordinate simultaneous release of the molecular pathology reports associated with surgical pathology. And the reports are still separate reports, but they will be released together. And this work really came about because after the 21st century information blocking legislation went into place, they were hearing reports of distress from patients because in their system, it was typical for the molecular pathology result to to be finalized first, and then this would flow to their patient portal, MyChart, and the patients would read it without the context of the surgical pathology report. Because the surgical pathology report was not released yet, the clinician couldn't help put the context of the entire picture for the patient. So they coordinated this with their 21st Century Cures Act governance body and got a plan in place. They used order linking functionality, and then they also built logic to essentially hold tests to be able to be released together. So in this workflow, the molecular pathology result might be final verified first, and then the logic would check to see if there was an associated surgical pathology specimen. If no, it could be released right away, but if yes, then it would then check to see if the search path result was final verified. If yes, it goes and releases, they release together. If no, this would then flow to an additional workflow where there was an automated in-basket message sent that was monitored, the box is monitored by pathology office, and then they would notify the associated surgical pathologist so that they would be aware that this case was pending and to be prioritized. And so once that was final verified, then the system automatically would release both together. So effectively, they've changed their workflow to create this integrated data. Another order linking solution that is pretty commonplace in Epic systems on the chart side is, well, this application is becoming common, but I would say it's overall a fairly newer concept to think about, where we look at lab data. So historically, and I say most cases even today, when you want to look at lab data, you go to the lab section of the EHR, right? You go to the results review grid, you go to the lab tab, whereas, that's really not where the data is the most useful. The data is most useful in line with the other data that you need to care for the patient. And so here I have an example of Epic's Phoenix transplant, what's called a checklist. And these are pretty common in systems that have Epic in transplant centers, and it's being pioneered for oncology now as well. But what this is a clinical view. This example is aimed at nursing, where there's a checklist of data elements that need to be reviewed, and in some cases tasks that need to be performed. And this will allow the users to view whether required lab testing for a workup has been done, and then also to link the exact result they want. And so this is agnostic to whether the test is AP or CP or blood bank. It's really related to whether the test has an order, which all tests do. And so for this example, the nurse can click on the ABO workup and pick the exact test that's desired to display and kind of cut out the noise from historical results. So those two examples I showed were from the clinical facing chart side of the EHR. The next example I'll give will talk about the lab facing side of the EHR. And I just want to call out that, until fairly recently in most systems, workers in the lab, in many cases pathologists, wouldn't necessarily need to access the EHR as a whole. And in many cases, lab staff may not have had access to the EHR. And so the historical LIS systems, the best of breed applications that have developed over time were really developed to allow labs to only work on those applications and really not have to go really elsewhere for that data. And likewise, the way that tests and test results and test data have developed in the EHR has really predominantly been to serve those needs for the chart-facing view. And it's relatively recently with the advent of integrated LIS and EHRs that we have now, this EHR vehicle that it's a single platform that we use to take care of patients, do orders, do documentation, view data, and has different functionalities for these behind the scenes team that includes lab. So with that said, the need to be able to see data in a meaningful and integrated way is very important for labs working in integrated LIS. And I'm going to highlight that with a use case that I think is a pain point for most systems, and that's this issue of shared or split specimen workflows. So shared specimens are when a single specimen needs to have testing performed in different labs, like the examples I just talked about previously with molecular and surgical pathology. And it's really imperative that all the labs involved in the testing can see the status, the sum total of the testing on a single sample, and ideally the status of the test at any given time. I want to call out that there will often, or I would say usually be, parallel analog, physical, logistical, and processing workflows alongside the digital workflows, and these may be happening sequentially or simultaneously in parallel. And frequently, the specimen may need to be triaged, aliquoted, decisions made if there's not enough to go around. And this will also usually involve separate test cases that are being created for the different labs for a single specimen. So the order linking functionality in Epic, which you may have all seen, is pretty commonly used in result reports. It's also usable for the lab side view, and it can be useful there, but it's not always sufficient. So I'm showing here an example of the outstanding specimen queue from our test environment for our HPV lab, and you can see they can see their list of patients with HPV molecular tests, and then on the right-hand side, you can see the linked ID for the associated cytopathology report. So this would be samples that are, getting both PAP and HPV testing, co-testing. So this can be helpful, but one of the challenges is refer to those, logistical workflows and specimen handling processes that happen in the lab. And, if this linking is happening at a step later in the beginning of that workflow, all those steps beforehand are vulnerable to error. And then another challenge is that the access to different Epic views is usually, each lab will usually only access either AP or CP beaker. And so that can be a big challenge. So a very timely, more detailed example is our HPV, our BD Core Roche HPV PAP brand new workflow, which went live at 6 a.m. this morning, and I'll find out after this talk how it's going, hopefully going well. But for this is really, a core example of AP-CP coordination and integration. And so the test is performed for a single sample, single swab from a gyne exam. There will need to be HPV testing, which is performed in a CP lab on a separate floor in the Mayo building than the cytology PAP testing. And our prior workflow was built so that specimens would generally start in the AP cytology lab. With the new workflow, there's had to be a lot of changes to the specimen handling, and the handling has been flipped so that now specimens will start for the most part, in the HPV lab and need to be triaged there. In addition, this functionality for the new instrument allows us to now offer primary HPV with reflex PAP testing in alignment with evolving guidelines. So I have a screenshot here of our newly released Epic order set that reflects, the different options that clinicians have, where there's, co-testing that either starts, they still have the option to start with PAP and reflex to HPV. They can get PAP with HPV regardless co-testing. They can get primary HPV with reflex to PAP, or they may choose, PAP only. So there's these different scenarios, and the testing choice will drive which instrument the samples need to go to first. And so the challenge I've highlighted here on this slide is that the orders in Epic may be created at different times, whether it's HPV in green here or the cytology in red. And then pertinent to that order linking, I showed the cytology case that would appear in the order linking, it happens later on. So this is really, the order linking functionality we have in Epic is really not early enough to help in this workflow. So the way that the solution we have come to deal with this is a combination of data and sequential processing. So through our workflow analysis, we identified that really the lab needs to be able to identify the destination of the sample at the point of the receipt into the HPV lab, so that they can then triage the samples to the correct first instrument for the workflow. And the way we have then achieved this is by creating additional orders at Epic that when the samples arrive first at the core lab and then go to the HPV lab, their processing in the HPV lab will drive label printing that makes it visible at a glance without having to look in the EHR, the final destination, and then the samples can be triaged that way. But I think this calls out, really a couple of key issues for labs. And one is that, for a high volume test, such as our PAP and HPV workflow, even if it would be, possible in many cases for somebody to look into the EHR and figure out, where a sample is going, that's not practical to do. And the persons in the lab may not have the EHR in front of them at all times. And then, additionally, we've had to model our workflow and build to be able to get this AP and CP data displayed in an integrated way that can actually allow the lab to do their work. So those slides, I hope, highlighted how that we do have some current strategies to link different sources of AP and CP data, but they really today involve highly manual. In some cases, we can still benefit from automated processes, and then in some cases, adjusting the workflow to actually create the integrated data view we need. And so this is already kind of representing a shift from that historical, MO of the data processes following practice. We think we're already seeing practice being altered by the data needs. And so kind of looking forward into the future, we'll carry on that theme. So there's an emerging kind of say philosophical and strategic concept of considering health data as an element in an ecosystem. And I think this is a departure from looking at health data as a single point in time that's for a single use. And so an example would be, I would say in many cases still today, it seems like the main purpose for a lab or pathology result data is to be able to care for, the patient in front of the clinician today. And while that certainly is the primary purpose and won't go away, there has been the need recognized to view data as having other lives and longitudinal impact beyond that. And if you take, the sort of ecosystem analysis analogy of a tree, if a tree will not only grow and have its own seeds, but it will, provide branches for birds to live in. And when it dies, it will become, part of the peat bog or whatever. But taking that concept to pathology, I highly recommend this paper, which goes through the exercise of walking through what the digital or a pathology ecosystem might look like using necropathology digital whole site imaging as a use case. So in this scenario, if a patient gets a kidney biopsy and a whole site image is created, there may be parallel sort of lives for that data. Whereas the bottom here, where in yellow, the sample is visually assessed and diagnosed and the patient is treated, that is one, and that is the immediate use case. But there can also be parallel routes for the data to be used for unsupervised or supervised AI applications. And all of these interpretation of a whole site image can create a secondary data specimens, so to speak, that can then go on to fuel downstream clinical knowledge and other types of knowledge. So thinking about the data this way helps, to think through what do we need for this data, apart from what's needed to care for the patient today. And it really helps, I think, drive the view from the needs of the individual, whether it's the individual pathologist, individual clinician, or individual system, to thinking in a more modular and interoperable way. So that all sounds incredibly exciting. I would say for most of us working in the operational practice environment today, we know we're not anywhere close to there yet. And it still often can feel like we are doing things the way that we were doing them, decades before. So why is it so difficult to change? And lab data is not alone in this. With all of the advances in medical guidelines that have come in the last 50 years, it's still estimated that only about half of healthcare is actually delivered in alignment with these guidelines. And there are many theories about change and complexity in systems, and as to how change can be hard to overcome. And I think from looking at it from the literature that conceptualizes health data in an ecosystem, it's helpful to think about, just like in a natural ecosystem, what are the influences that cause change or that prevent change? And so, in the biological world, systems can change when, when there's technological interventions from humans, which we of course also see in medicine, but then also when large events happen, like this happened recently with the COVID-19 pandemic. Sometimes resources and availability of personnel in healthcare will drive changes in practice. So external factors can help when we're trying to incite internal impetus to change. It's helpful to understand this. And then I think when you're inciting internal stimulus to change, it's very helpful to understand what the barriers are. And, consensus on barriers to change include cultural and political factors. Resource scarcity can be a huge barrier to change when there's a incentive to maintain the status quo, to avoid unnecessary worker burden that can't be tolerated, as well as once again, lack of acceptance of new practices. So I think most of us working in data have recognized that probably the biggest inciter of change on the horizon will be artificial intelligence. And so it can sometimes feel like we're sort of doing our daily work and waiting for AI to arrive and rescue us. I think there's a strategy and framework called AI readiness that kind of rejects that mentality. And it's this idea that, yes, not all of us will be actually actively implementing or developing new technologies today, but there is absolutely work that can be being done so that when we do implement the technology, we're meeting it halfway in, we're ready to hit the ground running. And so experts agree that some of the most important elements in AI readiness are getting your data into a state of availability, so essentially unlocking the potential of your data, and working towards having maximum standardization of data where you can, as well as getting your team culture and your system into place in terms of good practices for documentation, and having the necessary experts available. And this unlocking and availability of data and standardization become increasingly important as we transition from a traditional client-based infrastructure that I've shown here on the left, where this is really dependent in the past on these individual interfaces and sometimes physical connections being between different applications and instruments, to moving towards cloud-based solutions that will rely increasingly on modular interoperable data. And thinking about LIS systems, where historically it's been a lot of work to build each interface, that's really precluded. LISs will interface with the EHR, but historically they really haven't interfaced much with each other, whereas that is a real possibility in the future. So I want to keep moving because I know I have only a few minutes here. So kind of getting back to AP and CP data, or just even looking at it as data from disparate sources, right? Disparate labs, disparate LIS data sources, along with unlocking your data. This is important for the development of multimodal AI. And in the development of AI, it's been shown that maybe not counterintuitively, fusing multimodal data, which is to say, combining data elements from different domains like radiology with lab, or labs of different types, or labs with clinical notes, and then using that to train AI, and whether the data is fused at an early point in the training, or the models are trained independently and then combined later on or later. This leads to better performance in terms of prediction and diagnosis than using single modality approaches. So it's going to continue to be important to enable our data to be utilized in this way. So really enabling data for the healthcare ecosystem will depend on interoperability. Most of you are probably familiar with this concept in laboratory specialties, but this is really an overarching definition of the ability of systems to exchange and also to make use of information. And we generally achieve this in our health data using data protocols and standards, whether it's for terminology standards, transport protocols, and increasingly, technology standards as well. So the success of unlocking our data for integration will be on standardization and discretization. And I talked about discrete data previously. And so especially pertinent to our pathology data is we have a lot of unstructured data. And I would say even a lot of our legacy data that even started out as being structured, if it's ever been scanned or for faxing, it's now become unstructured. And I've purposely shown this example, which is a very kind of grainy historical scan, and it's easy to see how this could be pretty unusable in the future needs. So this concept of discretizing data is around extracting elements from previously unstructured data and turning them into discrete variables. And so you can imagine for an anatomic pathology report, it would be desirable to be able to discretize microscopic features, disease classifications, and diagnoses, et cetera. So for our retrospective data, there are solutions. We are using several of these solutions today, even operationally, although I'll say in a limited capacity. Optical character recognition is an AI technique used to process image formats and detect human features of human readable characters, and then create a probabilistic report output of that is in the format of text. And then this can be combined with other AI techniques such as natural language processing and deep learning to enhance the extraction and discretization of data. I'm showing this example as there are many similar examples in the literature, but just to show how this is both very accessible as a technique, but also I think still has key limitations to scalability. So there are a lot of studies like this. I've chosen one to highlight of how OCR can be used to discretize data. And so in this paper, the authors had historical reports, and they just used Adobe Acrobat, their OCR feature, and they text mined for three uterine associated path features, and they had a high concordance with the extracted codes, and the OCR performed better than manual abstractors. Now you can understand, like, this isn't even employing NLP, it's really just character recognition. And those pathology features that they chose, leiomyoma, endometriosis, is a pretty specific character strings, and you can see how this could become more complicated using more ambiguous phrases or character strings. And so part of the challenge of applying this broad scale and sort of making it plug and play is that especially anatomic pathology has tended to be kind of heterogeneous per system or even per pathologist. And so any of these efforts right now, still require a high degree of validation, or in automation cases, training and then validation. So when I look back at that figure of the model ecosystem applied to pathology, and I think about what that will mean to our LIS and EHR build, these are kind of the overlay questions I have. And so when I think about this example of a kidney biopsy, getting a whole slide image for future needs, if we wanted to separate medical renal biopsies from other types of renal biopsies, do we actually have our AP data built to a granular level? We can easily separate those out. Now, there are AI methods that potentially could be applied to clean the data up, but it's a lot easier if you've created the cleanest data you can up front for the most reliability. What kind of case-related timestamps are retained in our databases, or are generated and displayed in the EHR? And timestamps associated with AP cases can be important for correlating with different tests, such as CP or other AP tests, so that you're associating biopsy with other types of studies that are relevant to that patient's episode of care. And then, when we're working in our whole slide image viewer in current state in eSlide Manager, our pathologists, if they're annotating that data is not flowing back to our LIS, and likewise, there isn't data flowing from our LIS into our whole slide imaging web viewer application. But we know that is a future possibility, and that some vendors are actually working on that functionality today. So, thinking about that, if we're going to have data captured in more than one system, where is that going to be, available, and how are we going to be able to extract that? And I mentioned before, can we associate clinical or other lab data with our whole slide imaging data? And then even in a case where we may not have all of our pathology specimens that have whole slide images, which is the case for most systems today, including us, how are we going to be able to identify those that do contain that data for future research and data sharing? So these are all things about thinking about how this could be implemented in a practical way so our LIS build can capture future data needs. So with that, our test code team and our LIS team are actively working towards designing high quality clinical data for both the care we need today, as well as for future computational usability. So we do this in several ways. I'll show on the next slide. We assess the data design for downstream data needs, and then always working to increase, where we can, standardization and discretization of our LIS data outputs. And then now we're also coordinating among AP and our CP LIS analysts and teams, and also usually with non-LIS EHR teams when we design tools that will extend outside of the lab, such as decision support and then downstream analytics. So last slide. At a high level, I don't want to overwhelm you with this swimline diagram, but this is just the front end of our current test code change request process workflow diagram. But I just want to highlight how we have different roles from the person who, individual or group, who requests the change at the top, and we have a test code coordination team. We have LIS governance that includes myself and other LIS leaders, and then our analysts who work on the tests and support them, as well as non-LIS EPIC teams. And then we have to always consider outreach since we are a reference lab. And then calling out here, we have standardized points in our process now where we actually cross-consider for each test code whether there is cross AP to CP impact. And if so, then we have a process to involve, representative and assigned analysts from both, stakeholders from both, along with frequently non-lab stakeholders that we're coordinating with to approve. And the HPV example that's gone live is a key example where we have, I would say, an increasing number of tests, especially in the molecular pathology realm, where we have both AP and CP build involved. And then when it comes to governance, this is where we get to that high level of thinking about not just the data needs today, but for downstream in the future. And this is where we bring into play our test code team governance, sometimes consulting with other CMIO and other medical leadership to understand if a request is made, is this going to be, have widespread impact, but more will have widespread benefit. And sometimes we do, change the build or extend the build so that we can implement a solution, not just for, the single individual lab that requested it, but for others as well. So I'll stop there since I think we're getting close on time. And to summarize, hope I gave you a picture of how we got to where we are today in terms of the data that we work with, and highlighting, I think, the increasing need to have integrated data that, data is data regardless of what lab it came from. And in the current state, we can achieve this, but it is really in a pretty labor-intense way that's really not scalable for what we're going to need for the future. And so working as we can today to prepare our data and rehaul our processes to be in that state of AI readiness for the future. I'll stop there and ask if any questions. Thanks.
Dr. Graffin?
Yeah, Michelle, thanks so much. I really enjoyed that talk. I have a comment and a question. The comment is that as I think I have long been advocating for getting rid of this distinction between AP and CP. I think it's very arbitrary and it doesn't really do any service right at the moment. We in pathology are diagnosticians, no matter whether we're AP or CP. And I have a brief question. You have alluded to this very briefly. The other diagnostic department, of course, is radiology. And are there efforts to integrate any of the pathology reports with radiology reports, like you talked about integrating CP and AP a little bit?
Yeah, I'm not actively involved in any of those projects here. I have been at other places. So effectively, from an EHR perspective, radiology data is built in the same procedure category type as lab data. With that said, one of the challenges to really integrating it has been the standardized data elements that are used. And for example, radiology studies may be classified by, the mechanism used, or really we're identifying the clinical scenario where it's used. Is it for a specific diagnosis or protocol, and then linking those with relevant pathology studies has been, I think, the challenge. So I think using kind of I would say clunky mechanism of EPIC order linking, yes, that actually is done today. I think larger scale efforts to have a truly integrated report or display, I think hinge on the evolution of having an interoperable element to tie those to, whether it's something along the lines of using SNOMED diagnostics, but it really needs to be further up the diagnosis pipeline than after the patient's discharged and codes are assigned. And I think that's a big challenge for a lot of our data integration. Is we need that unifier up front, like when the patient arrives, when the sample is taken.
Yeah.
Okay, we are going to close for the day because of APCP.
Mhm.
Thank you very much, Dr. Stoffel.
Yeah, feel free to email
And-
me any other questions or stop by.
Yeah, get a hold of her via email. Thank you much.
Thanks.